Thank you, Sue, and welcome everybody. And I hear there are people from all over the world, Bangladesh and South America and India, and Canada. So welcome to everybody who's coming in from far away, as well as people from England. Before I start, I liked Sue's remark about wearing masks and trying to personalize and individualize our masks. I am indeed a supporter of wearing masks. I think it is your social duty, and I think the evidence that it protects people who are near you is really quite strong now. But I've personalized my own mask. I haven't dared wear it at work yet, but I'm a tremendous fan of the poet Philip Larkin. He wrote the poem Wits and Weddings and all sorts of famous poems, and lots of people in England absolutely love him. And I blog about him a lot on my blog. And the Philip Larkin Appreciation Society has produced a Philip Larkin mask, and I bought one. And when I go to the shops or into the supermarket, I wear it in the hope that perhaps a fellow poetry lover will come up and say hello. Wow. So that's my individualized mask. I'm the Professor of Obs and Gynae in Nottingham, home of Robin Hood. And Nottingham is an interesting centre with regard to COVID, because we've been let off fairly lightly in the first wave. We had our fair share of cases, but certainly much less than London or Leicester or Derby or Birmingham. And I'm an obstetrician. I was working all the way through the first wave, and we saw, I think, 7 pregnant women who had COVID-19, and none of them were significantly ill. They were all managed as outpatients. I think there was one patient who had very slight symptoms, but we didn't really have a problem locally. So you may say, why am I talking to you? Well, the reason I'm talking to you is that right at the beginning, I've been writing this blog, ripe-tomato.org, and I thought it would be a useful idea to collect the primary research on COVID-19 in pregnancy. So, I was cross because there seemed to be an awful lot of opinions, but there wasn't much in the way of facts. And so I just set up on my blog a list of all the original peer-reviewed papers, starting off with the first 9 cases from China in the Lancet, and now it amounts to 256 papers or some number like that. And every day we add a couple to it. As far as I know, it's still the world's only database of COVID-19 in pregnancy research. The World Health Organization also has a database, which I think is a little larger than mine, but it's still not been published. So I think, if you want to see the actual evidence that's been written, ripe-tomato.org is a good place to come. So please use it. And that's why I'm talking. I'm going to try. I'm very, very keen on talking about evidence and not opinion. So I'm very tough with people. If they ask me something and I don't know the answer, I'll just say I don't know the answer. I won't, I'll try not to give you too much opinion. Now, we've changed the order, the system this time from last time, and I've actually made a tape recording of my main presentation. It lasts about 7 or 8 minutes, and the plan is that we're going to play that, and then I'll come back on and I will take questions from anyone who asks. I think the chat is working, so feel free to just write questions into the chat, and I will be delighted to answer questions until you're all exhausted. Hello, I'm Jim Thornton. I'm speaking to you from Nottingham, the home of Robin Hood. And the reason that I'm talking to you is that I've been keeping a register of all the primary scientific reports on COVID-19 in pregnancy since the pandemic started on my blog, ripe-tomato.org. There it is, please visit. I'm going to talk about SARS and MERS very briefly, a little bit about the epidemic in China. Then I'm going to talk about some registry data, the best registries, particularly the UK registry, and then a few other countries where I think the registry data is less good. And then I'm going to finish with a little bit of information about the neonatal risks by how the baby was delivered, whether it was breastfed. If we go to SARS and MERS and remember where we were back in February, the experience with those two previous coronavirus epidemics in pregnancy was very bad. 3 out of 12 pregnant women who got SARS died, and 3 out of 11 who got MERS. 30% mortality. It was a terrible, terrible disease, and people were very worried until the first cases of COVID-19 in pregnancy came out of the Lancet. 9 cases published in the paper version in March. There was no severe disease, no mothers or babies died. Every baby had a cesarean section, but that was a very small series. But it didn't take all that long before the New England Journal reported all of the cases collected by the National Health Commission in China. Over 100 cases, some early pregnancy problems, but not related to the disease particularly. 68 births, quite a bit of prematurity, but mostly iatrogenic. No babies died, no mothers died. But that was very reassuring, but it wasn't completely reassuring because the newspapers, I've been collecting all the information in newspapers, and women were definitely dying of COVID-19. I've collected 231 newspaper reports of separate women with COVID-19 in pregnancy. 42 of them, that's a pretty high rate, had died, according to the newspapers. And the newspapers are probably right. But these include celebrities, Italian footballers' wives, the Prime Minister of the UK's fiance, and also it's clearly biased. They're going to include more deaths probably. So it's not a particularly good source. And one of the problems is the scientific papers are not a particularly good source. They're mostly case series, individual case reports, hospital series, very confusing, not representative of the general population. What we need is registry studies. And registry studies did come out. Here are the first 3. Italy, 77 women, pretty severe disease. 1 woman had ECMO, but no one died, and the babies did fine. Netherlands, 200, again, 6 on intensive care. 1 woman died, but the babies seemed to do fine. And France, the larger units in France, big series, some seriously ill women, 6 on ECMO, and some babies did die, probably of some of these most severe women. These are good data, but I'm biased. I'm from England, and I think the best data is the UK Obstetrics Surveillance System. It's been running for many years, run by this lady, Marion Knight, and it was set up to collect data in a pandemic just exactly like this. And they had a reporter in every centre, and every single UK obstetric unit reported data. And over the first wave of the pandemic, there were 427. You can see the spectrum of disease. It's very similar to the people who get admitted with COVID-19 outside pregnancy. The outcomes, well, not that good. 5 women died, 1%, and there were 7 stillbirths. I think this is probably pretty much the most accurate data for a developed country of COVID-19 with good data collection. That's the UK. You'll surely be interested in the United States. Well, the CDC reports huge numbers, 55 deaths out of 23,000 pregnant women with COVID-19. That's 0.2%. So that's 1/5 of the UK figures. It's not very reliable. 2/3 of the data in the CDC doesn't have the pregnancy status recorded. So there's a lot of scope for error there. The US also has the COVIDnet tracking system, which is a sample of US hospitals, and it reports how many people in the pregnancy age range with COVID-19 were pregnant. It was 9%. And then how many people of the same age range who weren't, in the general population were pregnant. It's also 9.9%. So that suggests that pregnant women are not having any more severe disease than other countries. Other big countries, Brazil has a huge number of maternal deaths, 124, but the denominator here is not pregnancies with COVID, it's pregnant women with COVID who also have acute RDS. So that's a falsely high rate, but the women did die. Mexico has reported the extra maternal deaths. It looked at the average of the number of maternal deaths over the preceding 5 years in the same period, and there were 86 extra during the pandemic. And India has just reported the COVID registry in Maharashtra state. That's the state that contains Mumbai. And there were 321 cases, but they didn't report the deaths. Oh dear, oh dear. And we know that they'd missed some because Nair, the biggest hospital in that series, has already reported 3 deaths, and Preg COVID excluded Lokmanya Tilak Hospital in Mumbai, which is the largest hospital, and that has also reported 3 deaths outside the trial. So unfortunately, we don't have good data yet for India. What about the baby transmission risks? Well, here they are. This is from my colleague Kate Walker, who's looked carefully at those pregnancies where the mode of delivery and the infection status was reported. And here we see that if you were born vaginally, the baby is less likely to be infected, 2.7 versus 5% if they were born by cesarean. If they breastfed, they're slightly less likely to be infected than if they were formula fed. Makes perfect sense because there will be antibodies to COVID-19 in the breast milk. And isolation status, a higher rate of infection if you're isolated from the mother than if you're not. So this supports WHO and all the experts' advice. COVID is not a reason to isolate the baby from the mother, to deliver by cesarean section, or to avoid breastfeeding. In conclusion, this is a very serious condition with mortalities similar to non-pregnant women of the same age, and the risk factors are about the same as the non-pregnant. Neonatal COVID is not too much of a problem. Infection is rare and rarely symptomatic, and not increased by being born vaginally breastfed or allowed contact with the mother. Thank you for listening.
Thanks for watching this video from the Maternity and Midwifery Forum. For more expert opinion and analysis, hit the button below to subscribe.